Good morning and good evening, everybody, and welcome to this session on the AMR, preparedness for the next wave, the pandemic of antimicrobial resistance. So my name is Juliëtte Severin, and I'm a clinical microbiologist at the Erasmus MC in Rotterdam in the Netherlands. And I'm really very happy that we had the opportunity to have this session. Indonesia and the Netherlands share a long history of collaboration in research and in education. And this is very much the case for antimicrobial resistance. And we will show this during the coming half an hour. And it's also a topic that really touches many of the sustainable development goals. So it fits well in this program. And I hope that at the end of this meeting, we will have a sort of a brainstorm session and an outcome of where to go with research and education on this topic and what we need for this. Can you have the presentation, the slides for me, Molly, because I'm not seeing any of the slides at the moment. Can you give me the first slide, please? We're now seeing the whole presentation backwards. So actually, I thought that this session was still going to be in the week of the World Antibiotic Awareness Week, but this yesterday was the last day of this Antibiotic Awareness Week, but I think it still is a very good opportunity. Many of us already had a lot of activities in the field in the last week. So you can see here on this screen, please go to www.menti.com, and there is a number for those that have a handphone by hand, or also in your computer, you can go to that website, because I'm going to ask you some questions here in the introduction and then later on during the discussion, and hopefully that will help to shape the discussion into a good outcome. Next slide, please. It's going very slow. So I will go to the, if you have seen the number, so to www.menti.com and 2194840. And I'm now going to the first question. In which country do you work? And I see that there are already more than 30 participants. Hopefully there were 90 participants that were going to join us. So I hope that everybody is finding the right Zoom link. So the number is again here on the top of the screen. So you can go there and see where you work, in which country, Indonesia or the Netherlands, or maybe somewhere else. Only 6 people have used it so far. Please go there. And because we don't have a lot of time, I will go to the next question. What is your profession? So medical doctor, veterinarian, science in sociology or anthropology, water scientist, government employee, somewhere in the industry or other. So we're already getting 12 people in this session. That's good. And for the sake of time, I will stop this now, but it's a wide variety. I already see many others. And we will use this questionnaire again in the discussion. So I will stop sharing. We go back to the PowerPoint slide, please. So the program of today, because of AMR, the One Health component is very important, and we will have speakers from the animal field, from the health field, and we will cover a little bit of the environment. Next slide, please. So this is the program. First, and now it's going a bit too fast. So, but I will. So the program covers first the people from the animal field, then the people from the health, human healthcare field, and then we will have two speakers on One Health overall. So we're talking about pandemics and the pandemic of AMR, but we're now in the midst of the pandemic of COVID-19. And what's so intriguing is that these two, of course, are interconnected at the moment. And what's also very interesting is that some countries that are doing a very good job in AMR, such as the Netherlands, we have a very low rate of resistance overall. We're not doing so well in the COVID-19 pandemic. There's some similarities in these pandemics, but of course, next slide please, also a lot of differences. And one of the main differences, it's a lot of text, but for the COVID-19 pandemic, it was probably a one moment, one event that a virus crossed the borders from the animals to the humans. But for AMR, this is happening much more frequently, and also in the environment, this plays an important role. So next slide, please. One Health is important, and it covers both human health, animal health, and environmental health. So we will now go to the first speaker, and we will start with the animal part. This will be covered by Dr. Imron Suandy and by David Speksnijder. Next slide, please. And I think Dr. Imron will start from, so please, next slide.
Thank you, Juliëtte. Can you hear me? I hope you can hear me properly.
Very well.
Okay, great. So everybody, participants in this event, my name is Imron. I work for Ministry of Agriculture of Indonesia. I would like to share how we handle the AMR pandemic. It's some lesson from our surveillance activities, where the activities at the beginning setting up by support of Netherlands expertise, and we try to learn something from the Netherlands side. Next, please. So this is how we set the AMU survey from 2017. So we conduct the activities in the three main provinces, which is a main production for the poultry sectors, especially for broiler commercial, representing the part of Indonesia, the west part, central part, and the east part. And from the three provinces, we conduct the survey and about 360 farms, broiler commercial. Next. And again, later on, we setting up the AMR monitoring on broiler commercial farm in Indonesia. From 2018, we already set all the systems, and the monitoring AMR conducted by 9 different laboratories. For the isolation, collecting sample, and identifying the target bacteria conducted by DIC, 8 DIC in 8 regions of Indonesia, and then the target bacteria which have been isolated and into the BPM SPH laboratory in Bogor to design for the antimicrobial susceptibility testing. And the specimen we are taking is the second from the poultry slaughterhouses. Next. And based on our activities, we are find that most of the antimicrobial usage in broiler commercial farms from our survey is the most used is enrofloxacin or the group of quinolone of antimicrobial. But we can see from the graph, the use of colistin is mostly used as a combination of antimicrobials. Next. And we also identify that the actors who influence in treatment decision making on farm is the technical staff of the supply contracts company, where the 80% of these people are not veterinarian. Next, please. Next, please. And based on our finding of AMR monitoring program from the general population of broiler commercial farms with the targeting E. coli isolated as the indicators, we can see that the colistin is getting resistance from the isolate we taking from the sickle of the birds, and also the pattern of the group of quinolones. We can see also the massive resistant on wild type are appear phenotypically, and it's confirmed being by looking the usage pattern from our survey. And based on this information, we further taking a measures from the policy side. Next, please. In 2007, we are, next slide, please. Slide. Okay, in 2007, we have regulation for ban antibiotic growth promoter regulation by Ministry Decree, and according to our information we got from the surveillance and monitoring program, we further ban colistin for animal use in 2019. Next slide, please. So this is the ministerial decree confirming the regulation of antimicrobial usage according to the information we got from the surveillance and monitoring activities. And in conclusion, I think I can say that the setting up the AMR survey as a project between Indonesia and Netherlands has successful to implement the science-based decision policy in Ministry of Agriculture of Indonesia. Next slide, please. I think that's all my presentation so far, so I will handing over to David. David, please.
Yes, thank you very much, Imron. Next slide, please. Next one. Yes, thank you. Oh, this is too far. One slide back, please. Well, from the data that which Imron just presented, we know that a lot of antimicrobials are being used in the Indonesian broiler sector. And we know that the resistance levels are relatively high, but still there are a lot of knowledge gaps. We know that, that a lot of antimicrobials are being used, but we don't exactly know the details of the antimicrobials that are being used at farm levels. And the amount of antimicrobials used at farm level, which classes of antimicrobials are being used to treat or prevent which kind of animal diseases. We also don't exactly know which diseases are present on the farm, so which diseases actually do need antimicrobial treatment and which ones do not need antimicrobial treatments. So the reasons why antimicrobials are being used are often not known. And what we also do not know what feasible and effective approaches are to reduce antimicrobial use on typical Indonesian broiler farms. And what we also do not know what the effects could be of reducing antimicrobial use in the broiler sector in Indonesia, what the effects will be on antimicrobial resistance rates. So for this purpose, we have developed our cornerstone research project with the aim to develop and test intervention methods in broiler production to reduce antimicrobial use based on existing practices and to measure the effects on antimicrobial resistance. Next slide, please. So in this project, we collaborate with multiple partners from both Indonesia and the Netherlands, and both from the private sector and the public sector. And we collaborate with veterinary researchers, laboratory specialists, experienced field workers, also with a pharmaceutical company, which also provides alternatives for antimicrobials and disinfection products, and also farm equipment. So it's a wide variety of partners in this research project. Next slide, please. And in the basis, what we do in this project, we will include 25 commercial broiler farms with at least 10,000 birds per farm. And in our baseline study, we will follow and collect data from 4 production cycles, so 4 different cycles of broiler production. And after these 4 cycles, we will analyze all the data that are being collected per farm. And we'll try with veterinary specialists and others to develop tailor-made recommendations per farm. So we will advise farmers well, what they can do to change their management to reduce antimicrobial use. Thereafter, in the intervention phase, we will support the farmer to implement our recommendations, and we will again follow this farm for production cycle and collect a lot of data. Next slide, please. And we collect a lot of data, and what we do collect are, amongst others, we provide a questionnaire about knowledge, attitudes, and practices. We collect a lot of data regarding the management of a farmer. So how does he perform in terms of biosecurity, hygiene practices, feed, water management, climate, etc. We will also collect daily records, some mortality, disease incidences, antimicrobial use practices, vaccinations, etc. We will check the climate, so we measure a lot of indicators for the climate, disease prevalence. What we also do is collect specimens to detect both the agent, so bacteria, viruses, and we do serology to check which kind of diseases are present on the farm. And what we also do is collect indicator organisms, so E. coli, and we will do sensitivity tests on that to get an indication of the level of resistance at farm level. Next slide, please. So we are now in the first phase, so in the baseline phase. So once we have finished it, we will collect all the data, and we will try to come up with tailor-made recommendations for the farmers. And possible interventions where you can think of is to train the farmer on basic biosecurity practices, on climate, on feed and water management. But we will also critically look at the existing treatment protocols, and we will also try to convince farmers to look for alternatives for antimicrobials. And based on the serology data and the PCR data, we can also try to adapt vaccination regimes to improve the efficacy of vaccinations. These are just some examples of interventions which we propose in our study. So this was a short introduction to our study, and hopefully within a year or so we can come up with the first report. Thank you very much.
Thank you very much, David and Imron. Next slide, please, for this view from the animal side. And we now go to the view from the human health side. So I'd like to invite Professor Dr. Kuntaman, a clinical microbiologist in Surabaya. Please, the floor is yours. And next slide, please.
Yeah. Okay. Yeah, I will talk about AMR Indonesia, especially focus on community, that we make some terminology of close or and open. Next slide, please. Yeah, it is our question. Does Indonesia have the problem of AMR? So we have a study since 2001, collaboration Indonesia with Netherlands. Then we try to identify the prevalence of AMR, especially ESBL producing bacteria. And the data show that since 2000, 2001, 2005, 2010, 2013, and in 2013, we have studied with WHO among 6 hospitals in Indonesia. Then in 2016, we try on behalf of Minister of Health, did surveillance among 8 hospitals in Indonesia. And we know that the ESBL prevalence among a patient in hospital range from 45 until 80%, average of 60%. So it is very, very high of the incidence rate of ESBL in Indonesia. Next slide, please. Yeah, and some study have been conducted in our university and around the city of Surabaya. The prevalence of ESBL producing gut flora with the indicator of E. coli in patient in medical ward, about 95% positive of ESBL producer. In pregnant women that visiting to the hospital, only 37, but in medical student until 50%. And you know that this 3 location is a close community. Close, it means that many contacts among them. Please, next slide. Yeah, next slide, please. Yeah, but in other location, like a pregnant woman in a community, only 28%, so lower than before. Back again. Yeah, back slide. Yeah, yeah. So in pregnant women in community, only 88% lower rather than hospitalized pregnant women. In neonatal age in primary health center, yeah, outside of hospital, 14%, but postneonatal age 37%. And I tried to collect the gut flora from the rural population in area of dairy farming, and we know that the prevalence of gut flora ESBL producer 34. So from this figure show that in open community in population average about 37%, but among close community, student and medical work is higher, very, very higher. Yeah, next slide, please. Next slide, yeah. Yeah. So in this figure, that in close community is more higher than in open community about the prevalence of ESBL producer. Next slide. Yeah, next slide, please. Yeah. So this is knowledge about the community close and open. Next slide, please. slide. Yeah, that the AMR increased by two methods. Overuse antibiotic usually impact on new mutant of resistant bacteria. Next slide. Yeah, and lower standard precaution or hand hygiene will also impact on the spread. Next slide, please. Yeah, so as a conclusion in this presentation, the AMR development, we have two kinds of AMR development, emerging by genetic mechanism and spread. Next slide. Emerging usually by higher use or abuse of antibiotic and spread. Next slide. Hand hygiene or hand washing. Next slide. Yeah, next slide. Okay. Yeah. So in closed community, it would be more spread than in open community. So this is our question. The smallest closed community is the family. Next slide. Yeah, so the gap, they start from the family, a bigger community like hospital, like in school, and then in open community, like in community, in primary healthcare, etc. Next slide. Okay, next slide. Yeah. Thank you very much. Please, over Juliëtte.
Thank you very much, Professor Kuntaman. You gave a nice overview of the problem of ESBL in Indonesia and touched upon quite some topics, including infection control. Unfortunately, the connection was not always very well, but your slides showed exactly what you wanted to show us. And I'm going to continue with this. Next slide, please. And you already mentioned in your first slide, Professor Kuntaman, the AMRIN study, which was the first population-based study of AMR among common bacteria in the commensal microflora, which was a collaboration between the universities and the hospitals in Semarang and Surabaya, and hospitals and universities in the Netherlands, including Nijmegen and Rotterdam. And Leiden. So this was funded by the KNW, Cordate and Perdaki. It was in 2001, and although the budget was not very high at that time, there were still 4 PhD theses coming out of this project. And it, next slide please, it also gave a great insight in the problem of resistance at that time. It was not really in the community, but really in the hospitals a problem. And the very nice outcome of the AMRIN study at that time was that it resulted in a self-assessment program for Indonesian hospitals, which was endorsed by the Indonesian government in 2005 and led to a capacity building program that still a lot of hospitals are having the benefits of. Next slide, please. So hospitals are really hotspots for the emergence and spread of AMR. And I wanted to show you more recent research that has been conducted over the past couple of years. This was in an intensive care unit in Jakarta, in a hospital in Jakarta, the Cipto Mangunkusumo Hospital. This was done by a PhD student, Juliëtte Rosa Saharman. And she showed that the next level of resistant microorganisms, so microorganisms that are resistant to carbapenem antibiotics, are widely spread in this setting. We also looked at transmission patterns with whole genome sequencing. This is in the bottom of the slide. And then you can really very precisely track how microorganisms spread in a certain environment, in an ICU. So we found this microorganism, this very resistant microorganism in patients and in the environment. So this is really to make the connection to the environment, that the environment is important for AMR, and not only the environment in the hospital. So for example, sinks or places where there is water. Also, it's also important outside the hospital. So next slide, please. This is a project, the Sampan project, that had just been started, and it's sponsored or funded by from the Dutch side, the ZonMW. And this is a smart surveillance strategy for carbapenem resistant Pseudomonas aeruginosa. And now we're not only looking to the hospitals and also the patients and the healthcare workers and the environment in the hospital, but also to what's coming out of the hospitals in the water and what's happening in the community, both in people and in the water. Next slide, please. Because especially in Indonesia, there is a strong link between water and humans, as was shown in this picture. There's a lot of flooding in Jakarta, and when there's flooding, there will be interaction between this water and people. Next slide, please. Another initiative that I wanted to mention here in this setting for a One Health collaboration is what's sponsored by the UK government, by the Fleming Fund. It's a fellowship program. And in this program, there are fellows from Indonesia and then mentors actually from the Netherlands. A couple of people who are now as a speaker or moderator are mentors in this program. And this is also with the purpose to really connect human health and animal health, and in this case also aquaculture health, and to try to see how we can connect better and really approach the problem of AMR together. So next slide, please. Because now we're really going to the One Health approach, and what Professor Dr. Heiman from Nijmegen and Radboud UMC will tell us a bit about the initiatives on this in the Netherlands. So please, the floor is yours.
Yeah, thank you for the introduction, Juliëtte. Next slide, please. So this is a painting from Albert Kuip from Nijmegen in the 17th century. That's where the Radboud Center for Infectious Diseases based, and I also tell a bit about generally some initiatives in the Netherlands, and particularly also the Netherlands Center for One Health, what they are doing. Next slide. So first, I want to sort of emphasize what One Health is all about. It should really be a collaborative effort of multiple disciplines to attain optimal health for people, animals, and the environment. But next slide, please. What we really see that the whole One Health concept still has a very anthropocentric focus. It's really about in the benefit of the human being, not in general for also the environmental and the animal health. Next slide, please. So we really need to think about how do we go from the human being being on the top of the pyramid, that it's really everybody's more or less equal. So from an ego-centric, human-centric or anthropocentric focus to a more eco focus. So this is a nice picture from a thesis from 2016. And next slide, please. And you really see that, yeah, also in Asia, and particularly low and middle income countries, the wealth is increasing. People want more access to more sort of protein-rich food. So you see also the meat production is hugely increased and really having a huge impact on our environment. And as we see that also AMR and environment and humans is very interrelated. And what we wonder now, and what we should think about, how the impact is of biodiversity on antibiotic resistance. So we go from a more less biodiverse, of a lack of diversity setting, and if we want to have really policies that will increase biodiversity, what will be the impact of AMR? I think that's an interesting question and a concept that we need to discover further. Next slide, please. And things that we do and should think about is, like in the Netherlands, we have a very good sort of antibiotic use efforts in the human sector, but we still see that in the animal sector. So that's on the left graph, we're really in a bottom low corner, so very little use of antibiotics, little resistance. And this is an example for penicillin. If you go to the right graph, ecological correlation of antibiotic use in the animals and in relation to resistance, that we're actually more in the upper right corner, and that is not the place that we want to be. But there are a lot of efforts in the Netherlands that are actually trying to reduce this. Next slide, please. So actually the antibiotic use in animals has really been reduced last few years. And the nice thing is that now together with the animal sector, we have a surveillance of both resistance and antibiotic use. And we reported on it very systematically every year. So this is the NetMap and the Moran. This is an example for 2015. And it's accessible on the website of, for instance, the SWAP and RIVM. Next slide, please. But besides having good policies, it's important to have good science. In the Netherlands, we have the effort for One Health based in the Netherlands Center for One Health. It's really a virtual center where different academic institutions and also the RIVM are involved to tackle the issue of multiple things, pandemics, but also particularly AMR. Next slide, please. Because Netherlands is really quite, as you saw in the first picture of Albert Cuyp, the painting, how the Netherlands looked several hundred years ago, but now we're way more people, 17 million people, and 120 million numbers of livestock, so way more animals than we have people, but quite different, more fragmented than we had several centuries ago, but a huge impact on environment and also on pandemics, also on antibiotic resistance. So an interesting setting to do One Health research with excellent partners. Next slide, please. And we have split the Netherlands Center for One Health in 4 themes. So we have the AMR theme, which is led by Mark Bonte. We have the Emerging Infectious Disease theme, led by Marion Koopmans. And then we have 2 other themes, Smart and Healthy Farming and Healthy Wildlife and Ecosystems. And we really have many different types of different disciplines, human, veterinary, but also environmental. We have microbiology, virology, ecology, molecular epidemiology, and more mathematical modeling. But also behavior is a really important issue. And I think behavioral sciences, the social science will become a more important partner in this Netherlands Center for One Health. So I think this is where I will end and look forward to the discussion later on. Over.
Thank you very much, Professor Heiman. And then we quickly continue to the Indonesian initiatives in One Health, and that will be covered by Dr. Annelies, clinical microbiologist from Jakarta. The floor is yours.
Thank you, Juliëtte. So there are 2 issues about One Health initiative in Indonesia that I want to share to you in this very good opportunity. So the first is about Indohoon, and second about our research experience on One Health. So Indohoon stands from Indonesia One Health University Network. This network was established in 2012 as a platform where leading academicians, stakeholders, scientists, communities, and professionals in Indonesia could transcend provincial and national borders to work together in achieving the best health for everyone. Indohoon has 20 university members, consists of 34 faculties, which is a medical faculty, veterinary, and also public health faculties. And it also initiated the establishment of One Health Collaborating Center in 5 universities. The activities and all achievements mostly are granted from USAID and BEP from US. One of the big achievements is establishment of One Health Laboratory Network, or OHLN, with the scope of work are linking university and government laboratories, providing, next please, providing training for lab personnel, and then advocate the development of laboratory virus management policy. And the gaps for this Indo-HUN is that we want to solve is to collaborate each other between government and university, and also referral system for early detection of emerging infectious diseases. Next slide, please. Our study about an eco-health approach in controlling AMR in human, animal, and environmental health was done in 2014 in 3 sub-districts in Central Java province, with the goal to explore, develop, and assess the effectiveness of a strategy for the proper use of antimicrobial in humans and animals to control AMR in Indonesia. And this study was done by multidisciplinary scientists, so in agriculture and also medical scientists. The study location were chosen because they have many small-scale pig farms and also layer chicken farms, and both farms were known as antibiotic user. There were 5 objectives as shown in this slide, but I want to highlight the result of 2 objectives, which is written in red fonts. So next, please. Yeah, in increasing local participations, which consists of farmers and non-farmers in controlling AMR, a total of 93 health volunteers in the community at a village level were trained to become bijak antibiotic cadres. So bijak means wise. Cadres were selected based on their willingness to increase community health. Next. Next, please. Yeah, we start the study with baseline assessment, which was done with focus group discussion method. Next. Then we conducted training using some method like simulation, role plays, and also class presentation. And then next, please, after evaluation, the cadres start to educate next their surrounding and they have to make notes about their detailed activities in their logbooks. Next, please. And after they had achieved certain number of activities, they got like a plaque as antibiotic cadre. Slide, please. And they hang it in front of the house, and they were very excited about it. Next, please. The next study result that I want to share is about the survey on antibiotic susceptibility of E. coli in pig farms. In this study, we isolated the E. coli from rectal swab of pigs and then feces from human, both the farmer and also the farmer families, wastewater as environmental samples. And this slide shows you the antibiotic susceptibility of E. coli isolated from 4 groups of samples, which are pigs, and then the farmer families, and wastewater of the farm. The antibiotic susceptibility patterns are similar, especially for ampicillin, chloramphenicol, trimethoprim sulfametoxazole, and tetracycline. So fortunately, we didn't find any ASPL producing isolate, even though that we found the resistant isolate against ceftriaxone. And the susceptibility pattern of E. coli isolated in chicken layer were similar with this result. Next slide, please. Yeah, so this is the future knowledge that we think will give good impact in controlling antibiotics. First is the spreading of this resistant organism in the food chain and environment, and then intervention to change behavior in consuming antibiotic in community. And the last is health economy, analysis of rational antibiotic use. So thank you.
Thank you very much, Dr. Annelies. And thank you all the speakers. I think these are very nice snapshots about what's going on in the field of AMR and what collaborations there already are between the Netherlands and Indonesia. But there are still many gaps of knowledge, as Dr. Annelies showed, and I think this is a nice opportunity to start the discussion, which will be led by Professor Jaap Wagenaar from the Utrecht University.
Thank you, Juliëtte. First, a logistic remark. How long do we have for the discussion? How many minutes?
Yeah, it depends on Molly. I think. I hope we still have at least 6-7 minutes or so.
Okay. Good. Yeah. Then I use that. Okay. My name is Jaap Wagenaar. I'm working in Utrecht University, and I'm a veterinarian. In fact, what we like for this session, we like to share data, as you have seen, but we also like to harvest, to hear from you what we can share also with the funding organizations and the organizers of this fantastic meeting. So what we like to harvest now from this meeting is, and we prepared a lot of questions, but I think we should limit it to 2 questions. And we like that you can put your answer in the Mentimeter. So Juliëtte, if you can, it was still on. Yeah, okay, there it is. So if you can go to the mentimeter.com and then use the code, we will see how that works. And if you don't have the Mentimeter and you want to share your ideas, you can put it in the chat that we will also use afterwards. But we will see if it works with the Mentimeter, if you can log in. And then the first question is about One Health, because we are talking about human health, about animal health, and about environmental health. But we like to hear from you where, according to you, in some keywords, where are the research gaps in One Health? And you can think about bacteria, you can think about mechanisms of resistance, you can think about techniques, you can think about disciplines. What do you think if, imagine that there will be a call for collaboration, where do you think that the aim of that call should be on? Where are the biggest gaps at the moment? And what disciplines or what techniques should be in focus there? So if you can put them now in the Mentimeter, I think, Juliëtte, I'm not logged on, but you have, I think, now an open space for the question that people can put in words, and then we can make a word cloud and see how it works. So, Juliëtte, can you update this about?
Yeah, it should appear in this slide.
Okay.
So there are no answers yet, or people are put it in the chat, but then I cannot see it. Ah, here it's coming. Complex systems approach.
So continue with putting in words. Let's see if it works. I do not see things showing up in the chat, so I hope that people are using the Mentimeter.
See, there's only one person using it at the moment.
Okay. Now maybe then it's better to because what you can do is to make these word clouds that you can see how many suggestions are made. But yeah, there it's coming. Yeah, veterinarian, village farmer. And I'm also thinking of the environment was what mentioned, but I think it's always a little bit underprivileged. Okay, there we go. Yes, very good. We see the midwives. Yeah, I noticed that there was somebody teaching in a nursing facility, I think. That. So here we see different disciplines showing up. So anthropology, psychology. So that are the disciplines we, as I'm a veterinarian, but as medical doctors, I think we are just starting with including them into the research, and I think it's very important to have them on board, because it comes a lot of what we see there to human behavior, what things are doing. Okay, so I think that's what we have at the moment. Very nice, very broad. And then I go to the second question, and it has to do with the second topic in this. That's not only research, but it's also education. And so we go to the next question. I think Juliëtte, you keep this, you save this.
Yeah, it's
okay.
safe.
Yeah, and then we go to the next question. So which topic in AMR needs more attention in Indonesia for education, and what level of students, what is the target population of students? So this will be a mixture of topics and in fact the target population. Because we, Juliëtte told already about PhD students and medical doctors that became a specialist in infection prevention and control. But we can also start in an earlier stage with even bachelor students or master students, or also can focus more on postdocs when they have already their PhD. So what do you think topic-wise, and what should be the people? You can just put it all into one word cloud. We will find out afterwards. So people now know how to use it. So that is really on how to use the antibiotics. Yes. And see if there are more topics coming in for education, or the level that we have to educate. Prevention, yes. There we have in fact the 2 pillars for AMR control. Right antibiotics, local habits, awareness. See, yes. And the risks, I think that's a very good thing. So in fact, we see the pillars of the infection prevention and control, with both at the animal side and at the human side, with focusing on antibiotics and focusing on the prevention. I've not seen yet what level we should focus on. It should be more the senior, or that we already have to start with people. I see in the chat somebody said for farmers when to use and when not. Also about antimicrobials. Okay, I think this is, we have only 3 minutes left for the hour. So I think this is what we could do in the discussion, just to get some ideas from you and to see how we can, in future collaboration, what the main topics are to work on. So Juliëtte, will you say the last few words with a kind of conclusion?
Yes, I will say some final words before the Zoom meeting will automatically stop. I want to, first of all, to thank all the speakers and also the audience for this input. I think it's very interesting to see that behavior in the first slides, when we're talking about gaps of knowledge, I think the behavior becomes very prominent. So the input of sociologists and anthropologists, and I think this can also be a common theme because it's necessary for the human health, but also the animal health, and maybe also how we deal with the environment. And the other topic that came out for education, what I found was interesting is not only, of course, the right use of antibiotic, but also infection control. And this is also could be an interesting link, how to do infection control in hospitals and how to do infection control in farms. And maybe we can have some interaction there and see if we can learn from each other. So I think these are some nice topics that were brought up by the audience. I think it's obvious that there is still a long way to go to combat the problem of AMR in Indonesia. And what we previously discussed in preparing this meeting, funding, of course, is very important, but the funding should have a good focus, of course, so that it can have outcomes that are also useful for really practice. And this, of course, affects the goals, the sustainable development goals that we're talking about today. So with this, I would like to end this meeting. Once again, thanks all to the speakers, and thank you all for the audience for putting this for your input. Thank you very much.